The monitors are alarming. The IV lines are just, well, a totally tangled mess.
Yeah, it is absolute chaos in that room.
Right. And the patient lying in front of you is completely unresponsive. Their breathing is really shallow. And as a newer nurse, your adrenaline is just, absolutely peaking.
Oh, 100%. It is terrifying.
But the active seizure, the dramatic, chaotic part that looks so scary to anyone watching, is actually over.
Right.
But the truth is, the most dangerous phase, and really the true test of your clinical judgment, has just begun.
It is so deceptive because, it feels like the emergency has passed.
Exactly.
The physical convulsions have stopped, and the room might even quiet down for a second, but physiologically, the patient has literally never been more vulnerable. They are completely defenseless against their own body right in that exact moment.
Welcome to an episode of the Super Nurse Podcast. Today's conversation is built entirely from the clinical notes and bedside teaching of Brooke Wallace.
Yes.
She's a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor, and a published author.
And just to be completely clear right up front, we are not Brooke Wallace.
We are definitely not. But our mission today is to take her hard-won bedside knowledge and really help you, the nursing students and new grads out there, bridge that massive, intimidating gap between, passing multiple choice NCLEX questions and actually keeping a vulnerable human being alive when things go sideways at the bedside.
We want you to stop just memorizing textbook phases and start recognizing actual clinical patterns.
For sure. Oh, and before we get into the heavy clinical pathways, we want to warmly invite you to subscribe and watch the visual video version of this discussion on YouTube. You can find the link right down in the description for our channel, Super Nurse AI.
So let's talk about those textbook stages. In nursing school, you learn this rigid breakdown, right? The prodromal phase, the aura, the ictus, and then the postictus.
Right, the neat little boxes.
Yeah, but standing over a real patient, the postictal phase does not look like a neat textbook definition at all. It looks incredibly messy.
It really does.
Yeah.
So let's break down the pathophysiology of what the nurse is actually witnessing the second the convulsing stops. Because during the active seizure, the brain just endured this massive, chaotic electrical storm.
Yeah, we are talking about millions of neurons firing completely uncontrollably.
Oh, wow.
And think about the metabolic demand of that event. The brain burns through its supply of ATP, which is cellular energy, at just an astonishing rate.
Right.
It consumes massive amounts of oxygen and glucose, and that leads to a huge buildup of lactic acid in the brain tissue. So when the shaking finally stops, the brain isn't just resting, it is entirely depleted.
Completely wiped out.
Exactly. The neurotransmitters are wiped out, and the cellular environment is incredibly toxic.
Which kind of reframes the entire presentation. I mean, if a patient is exhibiting extreme fatigue, severe confusion, or profound sleepiness, it isn't just that they are tired from shaking.
No, not at all.
Their brain is functioning like a computer that just suffered a critical hard drive failure and is performing a very slow, glitchy reboot. Nothing is loading correctly.
That is the perfect analogy. And that glitchy reboot requires time and metabolic resources. The brain literally needs to clear out the cellular waste, replenish its glucose, and reset its electrical circuitry.
Right.
Which is why you might also see the complete opposite of sleepiness. Because the frontal lobe, the part of the brain that regulates logic and emotional control, is temporarily offline, the patient might actually wake up wildly agitated or terrified.
But wait, I want to push back on our nursing instincts here for a second. When you see a patient who is suddenly that unresponsive, groggy, and confused,
Right.
your immediate instinct is to stimulate them.
Oh, absolutely.
Like you want to vigorously wake them up, maybe do a sternal rub, and perform a full aggressive neurological exam just to make sure they haven't suffered permanent brain damage or a stroke.
It's honestly the most natural human instinct in the world to want to see them wake up and just, prove they're okay.
Right.
But what clinical experience shows is that aggressively forcing them awake is absolutely the wrong move. You must allow them to rest. Yeah, because if you force a glitchy nervous system to run complex cognitive tasks before it has finished booting up, you can severely agitate the patient. Or worse, you can push the brain's electrical threshold right over the edge and trigger a secondary seizure.
So instead of playing the role of the aggressive neuroevaluator, the nurse's role shifts entirely to preservation.
Exactly.
You provide gentle, calm reorientation, you use a soft voice, tell them they're safe, and immediately redirect all of your clinical focus away from their cognitive state and directly toward their ABCs, airway, breathing, and circulation.
Because we have to factor in the pharmacology of the situation too. Like, how did the seizure actually stop? In many hospital settings, to break that electrical storm, The medical team likely just pushed intravenous benzodiazepines.
Right, medications like lorazepam or midazolam.
Yes, and those medications work by aggressively enhancing GABA, which is an inhibitory neurotransmitter. It successfully slams the brakes on the electrical storm in the brain, but it also heavily depresses the central nervous system.
So the very medication that saved their brain is now actively suppressing their respiratory drive.
Precisely. Which means, while you are allowing the exhausted patient to sleep and recover, you are watching their respiratory rate and oxygen saturation like a hawk.
Yeah, because between the metabolic exhaustion and the heavy sedatives actively circulating in their bloodstream, their respiratory drive could bottom out at literally any second.
And because they are heavily sedated and cognitively offline, they've lost all of their natural protective reflexes. The patient cannot protect their own body, which means you, the nurse, must become their ultimate physical barrier against secondary injuries.
Let's walk through that postictal physical assessment then. The patient is flaccid, and we are moving systematically head to toe. The first place you look is inside the mouth, which, by the way, can be incredibly difficult if their jaw is still tightly clenched or if they're combative.
It really can be. But you are looking for severe oral trauma because during the clonic phase of a seizure, the jaw muscles spasm with just incredible force.
Right.
So it is very common to see that the patient has severely bitten their tongue, their inner cheek, or even cracked their teeth.
Which means the nurse is going to see pooling blood mixing with heavily foaming saliva. And if we connect this back to the lack of protective reflexes, that fluid becomes a lethal threat.
Oh, absolutely.
If they don't have a gag reflex and they're lying flat, all those bloody secretions are heading straight for the vocal cords. What is the actual physical maneuver we do right then and there?
The evidence tells us that the side-lying position, the recovery position, is the most critical physical maneuver you will perform. You do not wait. You immediately roll that patient onto their side.
Because it's a matter of pure physics, right?
Exactly.
When a patient is flat on their back, gravity pulls their flaccid tongue backward, physically occluding the airway. And any pooled fluids will just sit directly over the trachea. If they inhale that blood or saliva into their lungs, you're looking at aspiration pneumonitis.
And aspiration pneumonitis is devastating. If acidic gastric contents hit the delicate tissue of the alveoli, it causes a massive chemical burn inside the lungs, which drastically increases mortality.
Wow.
Yeah, so by rolling the patient onto their side, you are using gravity to your advantage. You allow those thick secretions and vomitus to drain safely out of the mouth and onto the bedsheet.
Gravity is a great first line of defense, but it shouldn't be the only one.
No, not at all. Bedside suction equipment and oxygen flow meters must be fully set up, connected, and functioning before a seizure ever happens.
Right.
Seizure precautions are a mandatory proactive nursing responsibility because if you are scrambling around the room trying to untangle green oxygen tubing or, searching drawers for a suction tip while your patient is actively choking, you have already lost the window to protect them.
Yeah, that is a terrifying situation. And while they are safely positioned on their side, you also want to quickly loosen any restrictive clothing around their neck and ensure there is a pillow under their head if possible.
Exactly, to prevent their head from striking the hard bed rails if they start to thrash as they wake up. You are systematically securing the environment. You also have to assess for incontinence of urine or stool, which is incredibly common.
And the indignity of that moment is something nurses really have to handle with profound grace.
It happens because the massive autonomic nervous system discharge during the seizure ultimately leads to a total loss of sphincter control.
Right.
It is just an incredibly vulnerable situation. The patient wakes up confused, exhausted, and sitting in soiled linens. Your professionalism and your calm demeanor in that moment are vital to preserving their dignity.
Knowing how to physically protect the airway and the patient's dignity is essential. But knowing exactly where you need to be during this chaotic aftermath is heavily tested on the NCLEX, and more importantly, it dictates real-world survival.
Yes. This is the absolute, non-negotiable golden rule of seizure management. You do not leave the patient alone immediately after a seizure.
This is a notorious trap for new nurses.
Yeah.
An exam question or a real-life scenario will present a crashing postictal patient, and your brain immediately looks for a solution outside the room.
Right.
Like, you want to run to the hallway to grab the charge nurse or run to the Ponex for more Ativan. It feels productive to go get the doctor. Why is that such a dangerous trap?
Well, the temptation to leave is driven by panic, right? You feel overwhelmed, so your instinct is to run toward an authority figure. But if we break down the bedside timeline, leaving the room is catastrophic.
30 seconds out of the room is literally an eternity for a postictal patient.
Exactly. The patient is wildly disoriented, drowsy, and potentially agitated. If you step out, an uncoordinated patient could easily attempt to climb out of bed, bypass the padded rails, and suffer a traumatic brain injury on the floor.
Oh.
Or they could silently vomit, aspirate, and completely arrest while you were standing in the hallway looking for the doctor.
So you are physically trapped in that room, which means you have to utilize the tools around you. You lower the bed to the absolute lowest position. You ensure all the side rails are up and padded.
Yeah.
And to get help, you use the emergency call bell. You pull the staphysys cord on the wall. You literally shout into the hallway. You use whatever means necessary to bring the team to you. Never abandon the bedside.
And once the team arrives, the airway is secure and the patient is stabilized, the clinical priority shifts. Your hands have done the work to keep the patient safe. Now your brain must act like a high-definition video recorder.
The documentation, and this isn't just bureaucratic paperwork. The nursing documentation is the exact diagnostic tool the neurology team uses to figure out what just happened to the brain.
Exactly. Let's walk through the specific details that must go into the medical record. First and foremost, the precise start and stop time of the active seizure. Time is the most critical metric.
Because we are watching the clock for status epilepticus.
Yes. Any continuous seizure lasting longer than 5 minutes, or multiple seizures occurring back-to-back without the patient regaining consciousness, is status epilepticus. It is a dire medical emergency.
What actually happens at that 5-minute mark that makes it so lethal?
Well, at 5 minutes, the metabolic demand we discussed earlier completely outpaces the body's ability to deliver oxygen to the brain. Furthermore, the neurons begin releasing toxic levels of glutamate.
Okay.
And that leads to a process called excitotoxicity. The brain cells literally begin to excite themselves to death. Irreversible neuronal damage and systemic cardiovascular collapse are imminent at that point.
So those exact timestamps in your charting trigger the massive medical protocols required to stop that cascade.
Right.
But beyond the strict timeline, the nurse is the sole witness to the physical manifestation of the seizure. And the specific movements you document act like clues for the neurologist.
We need to note exactly which body parts were involved and how the movement progressed. Like, did it start with a twitch in the left hand and then spread up the arm? What was their eye deviation like? Were their eyes fluttering rapidly, or were they forcefully deviated to one specific side?
Because if we just write in the chart, patient had a seizure, we've given the medical team absolutely nothing to work with. How does detailing a left-sided hand twitch or a specific eye movement actually help diagnose the patient?
You are providing the team with a functional map of the patient's brain. The human brain is highly localized. If your documentation notes that the seizure started specifically with the left arm or that the eyes forcefully deviated to the left, that tells the neurologist that the electrical storm originated in the right hemisphere of the brain.
Oh, wow. So the physical symptoms point directly to the anatomical source of the misfiring.
Exactly, near the motor cortex or the frontal eye fields. You also have to document any triggers or auras the patient reported right before they lost consciousness. Did they smell something strange, like burning rubber? Did they experience a sudden visual hallucination?
Because an olfactory hallucination points to the temporal lobe, while a visual aura points to the occipital lobe. You're literally charting the geographic origin of the electrical storm inside their skull.
Your documentation must also capture the medications given, the patient's physiological response, and the exact recovery time. Like, how many minutes or hours did it take for the patient to return to their baseline cognitive function?
And that recovery time is a crucial piece of data, especially for the patient's long-term trajectory. If we are tracking prolonged recovery times, or if the seizure patterns are worsening over days and weeks, that drastically alters the care plan.
It changes everything for the family. Your detailed charting helps the healthcare team assist the family in care planning and involving them heavily in healthcare decision-making.
Which is where practical bedside nursing intersects with long-term lifestyle management. For example, highly tested NCLEX interventions, which are really just examples of excellent holistic nursing, revolve around keeping the patient nourished and safe when their nervous system is fragile.
Right.
If they're having frequent seizures, they are likely sleeping through standard meal times and missing vital nutrition.
So you have to start strictly monitoring their food and fluid intake. The medical team might implement interventions like offering finger foods that the patient can easily grasp and eat safely away from the table, maybe in a comfortable chair or bed, reducing the risk of a fall.
You also have to consider sensory input. A damaged or highly irritable nervous system can easily be triggered by sensory overload. So a crucial intervention is minimizing noise and distractions during mealtimes. You are modifying their entire environment based on the data the nurse collected.
And we also must acknowledge the harder realities of progressive neurological decline.
Yeah,
In cases of untreatable brain tumors or refractory epilepsy, worsening seizures and prolonged postictal comas might actually signal a transition in care. Your nursing notes are often the catalyst for the medical team to include the role of hospice and palliative care.
ensuring the patient's comfort, dignity, and quality of life are prioritized when curative treatments are no longer effective. The nurse's documentation really drives those essential, compassionate conversations. It is incredibly heavy, but it showcases the true power of bedside vigilance.
Let's do a rapid-fire recap of the most important lessons for our students and new grads.
Let's do it. First, the postictal phase is the aftermath of a massive metabolic marathon. The brain is exhausted, depleted of ATP, and desperately needs a reset. Resist the urge to vigorously stimulate the patient. Let them rest, but monitor their respiratory drive relentlessly.
Second, airway protection is paramount. Remember the physics of the side-lying recovery position. Gravity will drain those bloody secretions and vomitus away from the trachea. And never wait for a crisis to check your equipment. Your bedside suction and oxygen must be set up at the start of your shift.
Third, respect the golden rule. Never, under any circumstances, leave a postictal patient alone in the room. They are confused, impulsive, and at massive risk for falls and airway compromise. You are the lifeline. Lower the bed, pad the rails, and shout for help, but stay planted at the bedside.
Finally, treat your documentation like a vital diagnostic procedure. Capture the exact start and stop times to monitor for status epilepticus. Detail the specific physical movements, eye deviations, and reported auras because you are handing the neurologist a map of the electrical storm.
It all comes back to the reality of standing in that room. While the oxygen and the advanced neurology keep the patient alive, the human element of your nursing care is just as critical.
Your calm, steady presence anchors the entire situation, holding their hand, using a soothing tone, and gently reorienting them as they wake up, terrified and confused. That profound compassion is a massive clinical intervention.
When you understand the deep physiological why behind these interventions, the terror of the alarming monitors starts to fade. You can step into that chaotic room and think, okay, this matters, but it actually makes sense now, and I can use it at the bedside.
You move from reacting out of fear to acting with clinical purpose.
I want to leave you with a final thought to ponder. The next time you are sitting at the computer charting the details of a seizure, remember the sheer power of your observation. Your specific note about a brief left-sided facial twitch or a strange metallic taste the patient reported just before losing consciousness. That seemingly minor detail might be the exact puzzle piece that helps the medical team locate a hidden brain bleed or a silent growing tumor.
You aren't just a bystander. Your bedside vigilance is literally the ultimate diagnostic technology in that room.
Thank you so much for joining us for this clinical conversation. We warmly remind you to head over to YouTube to watch the visual video version, like, subscribe, and leave a comment, sharing a time you had to manage a challenging neurological situation at the bedside.
We also invite you to visit supernurse.ai for incredible resources, study guides, and tools to help you become the super nurse you were born to be.
Stay vigilant out there. Until next time, remember that the true test of your clinical judgment isn't just when the monitors are screaming during the storm, but in how fiercely you protect the patient in the quiet, vulnerable moments right after.